thank you, and welcome everyone to Cancer Center Grand Rounds. And really pleased with how we continue to innovate on formats in this new Zoom world of the pandemic. And I think today's session is going to be interesting given the nature of 4 speakers at various levels of their training and professional development in our cancer center and our university and healthcare system. And, you know, really focused on the great work that's going on in radiology and biomedical imaging and the science associated with it, most notably in interventional oncology. And I'm pleased to introduce, let us say, the leader for today's session, Dr. David Madoff. As you may recall from last week, Dr. Madoff is the co-director of interventional oncology, of the Interventional Oncology Research Lab, vice chair for clinical research, and the section chief for interventional radiology in Department of Radiology and Biomedical Imaging. And David really has, throughout his career, been an innovator in this space. And with his joining the faculty at Yale now a couple of years ago, I guess, has really built out not only the capabilities in our clinical operations, but expanding research, which is really exciting. And so, David, I turn it over to you to sort of introduce the other speakers and share with us all this great work.
Okay, thanks, Charlie. So I'd like to again thank you for giving me the opportunity to speak at Yale Cancer Center Grand Rounds. As you saw last week, I was part of a session on the multidisciplinary management of colorectal liver metastases. Today's session, as you stated, will be focused on interventional oncology, what it is, and some of the exciting research being done in our lab at Yale. Therefore, this program will focus on work being done by our trainees and not really on my own personal work. I will just be introducing the topics and our vision and goals for the interventional oncology program at Yale. So this session, as you may recall, was originally planned for March 10th, and it was just after the COVID pandemic. So interestingly, it's actually given us more time to make our data even more mature. So for the audience for today, so I'm really pleased, I think, about that. So I'm going to start, and then we'll be followed by Julius Chapiro, who happens to be the co-director of the Interventional Oncology Lab with me. He's actually an assistant professor of radiology and biomedical imaging, while actually still an IR resident. So that shows you the level of achievement that some of our colleagues really have. And then we'll be followed by Jessica Santana and Zeevi, who are both graduate students in our lab. And the work will all be talking about liver cancer and interventional oncology related activities. So let me just share my screen. Okay, so really, what is interventional oncology? Well, interventional oncology is a subspecialty of interventional radiology that utilizes minimally invasive image-guided procedures to both diagnose and treat patients with various forms of cancer. The benefits of primary interventional oncology treatments are its immediate tumoricidal effects. As you, I'm sure, are aware, they're minimally invasive, resulting in cost reductions and time efficacy, as well as having minimal systemic side effects, leading to an overall improved quality of life. The goal has been to make the case for us becoming the 4th pillar of cancer care. And over the years, I believe we have. And this has been shown actually in many ways. These include having IO therapies incorporated into multiple NCCN guidelines, which include, colorectal metastases, include HPV, and even in renal cancer. Having trials to assess the role of percutaneous management of cancer, and what I believe is most important is that I believe we've now become a valued participator in most, if not all, of the tumor boards. So what does it take to become a pillar of oncology? Clearly, each clinical discipline needs to have a strong foundation in basic translational and clinical research. We do have some work to do in this regard, but I must say, I was really thrilled to see when I was in 2016 as an invited faculty of ASCO GI, my discipline next to my name was listed actually as an interventional oncologist, not an interventional radiologist. So I was really happy at that time, and I thought we actually made it. However, I really do believe that in terms of research and education of referring physicians, I think we're nearly there and on the right track, but I don't know if we've come there totally. So here you can see a long list of procedures that we do in IO. These can range from image-guided biopsy, primary tumor therapy, palliative procedures, central venous access, and managing of complications that are either a result of the cancer itself or related to cancer treatments. So I just wanted to highlight some challenging biopsies, as this is one of the most important procedures that we do. Clearly, it is difficult for oncologists to treat patients in the absence of a diagnosis. That said, cases such as this one should be easily doable for any experienced interventionalist. And as you can see, this patient has confirmed metastatic adenocarcinoma. So here's a second case, which I would say is much more challenging due to lack of any imaging finding on CT or ultrasound. And you can see here, it's close proximity to the heart. Fortunately, we were able to get adequate tissue sampling and help this patient get the appropriate chemotherapy that they needed to be on. So I just wanted to discuss a couple of primary interventional oncology tumor therapies, both of which will be discussed in research by our trainees later in the session. Here we have tumor-guided ablation, or image-guided tumor ablation. So the goals of ablation is to eradicate all viable malignant cells and spare normal surrounding tissues, treat tissues with unfavorable location or pattern of distribution for resection, and or have multiple comorbidities. These are the most often used in patients with low volume disease and require debulking, are typically done in an outpatient setting, and these procedures are repeatable. So if we can see here, we have radiofrequency ablation and microwave, which are heat-based therapies. We have cryoablation, which is a cold-based therapy, and we actually have irreversible electroporation, which is really to electrocute the tumors, believe it or not, by changing the ionic potentials between the membranes. So ablation of liver tumors, was its initial indication, is shown here. And this is one case of a patient with HCC that needed ablation as a bridge to a transplant. As we can see, 2.5 years later, no tumor recurrence or any residual disease. Next, we see a case of an isolated colorectal liver metastases, who here you see a PET positive or hypermetabolic lesion in the right lobe of the liver, who was successfully treated with ablation and is tumor-free at 1 year follow-up. This is a patient who, instead of having a liver lesion, has a lung nodule. Here we can see that based on having heat-based thermal ablation, the patient did very well at 7 months. As you can see, there's no residual tumor on the imaging, and there was no local recurrence seen at 3 years. We can also treat bone metastases. This is a patient with metastatic breast carcinoma with a focal right femoral and right hip pain limiting mobility. For whatever reason, she refused radiation therapy and was treated with heat-based thermal ablation and cementoplasty, as shown here. And she had an immediate improvement in right femoral pain from 8 to 10 out of 10. This is a very interesting use of thermal ablation, in this case with cryoablation. This patient had metastatic rectal squamous cell carcinoma who had severe intractable 10 out of 10 pain secondary to inoperable tumor recurrence impinging on the sacral nerve roots. She was successfully treated with partial cryoablation of the bowel wall, and you can see right here the low density ice. She had immediate, or I should say complete resolution of her pain within about 3 days. So she had actually no pain up until a year, at which time she actually died. And then lastly, we were able to treat this liver tumor here that was abutting the left hepatic bile duct. So we used IRE, again, that's basically electrocution, which is technically a non-thermal ablation. So about 9 months later, the patient has no residual disease or recurrence. We also have more regional therapies such as transarterial embolization, and these cases are typically reserved for patients with higher tumor burdens or are in neoadjuvant settings, or in cases where resection or ablation is in a location considered technically difficult or dangerous. Here we see a case of a patient with HCV cirrhosis and a 4.8 centimeter segment 8 HCC. Embolization was performed to maintain the patient on the transplant waiting list. We see complete necrosis, and she ultimately underwent a transplant. This is a patient with compensated HCV cirrhosis and a solitary HCC in segment 8 and a platelet count of 57, who also needs treatment as a bridge to transplant. This tumor, as shown here, is in a very difficult location, and she successfully underwent embolization with no residual tumor, and this patient also underwent liver transplantation. Here we're able to see a patient that was treated in their 90s who has a large HCC. In this case, the HCC actually ruptured through the capsule, and as you probably are all aware, this is associated with a poor, if not dismal, prognosis. We were able to successfully treat it with radioembolization, which was done as an outpatient, and as can be seen here, she had a complete response and lived up to 4 years later. And then lastly, this is a case of a patient that has bilobar HCC with extensive portal vein tumor thrombus. So typically, this patient would have less than 6 months to live, but as expected, this is a relatively young patient with a family, small young children, et cetera. So we tried to offer a procedure to help this patient, and we did chemoembolization, and fortunately, we were successful in prolonging his life for about 16 months. So to wrap up, I just wanted to give you my 5-year vision for a modern academic evidence-based interventional oncology program. First, we want to increase the IO clinical and research programs throughout the Smilow Cancer Hospital and care centers throughout the area. Further, it'll be important to improve the education for the community provider of the procedures that we offer and which patients are more likely to benefit. We also need better integration of care into current and future oncology workflows. We will be working on initiating some new clinical trials related to liver oncology. One was discussed last week on liver regeneration, which was the Dragon 1 study, but we also are going to be involved in the LEAP 012 study, which is going to be on chemoembolization plus or minus immunotherapy that we're going to be initiating or starting very soon. And then it's also going to be critical to have faculty who are subspecialized to be able to provide this level of advanced care. We also plan to make image-guided biopsies more readily available and hoping to improve turnaround time. There have been ongoing discussions with Dr. Chen Liu, who, as you all know, is the chair of pathology, to work on an image-guided biorepository. As will be seen from the next speakers, we are currently working on advanced preclinical and translational research with a focus on molecular imaging and immuno-oncology. We're also very active in machine learning and artificial intelligence as it relates to liver cancer. And based on these interesting topics, we hope to be able to achieve and expand our funding. And lastly, we have a newly established IR residency program. In this, we would like to develop an interventional oncology fellowship, and we are looking into the possibility of applying for a T32 training grant. So, with that, these are our visions and goals. I'd like to then introduce my co-director for the Interventional Oncology Research Lab at Yale, who will be discussing quantitative biomarkers, molecular imaging, and artificial intelligence to guide the therapy of liver cancer. So thank you for your attention.
All right. Thank you very much, everyone. I'm really excited to be presenting this topic on behalf of our lab, and this is more of a vision presentation of what we've accomplished and a couple of thoughts that we put together over the last years. None of this would have been possible without a really vast infrastructure of collaborators, which I'll be talking about a little bit later. I want to say that I'm very excited about David joining the group here and really being our new leader in interventional oncology, and we all completely subscribe to the vision that she just provided. So as you know, I'm going to be focusing on the liver cancer, and primarily I'm going to start off with the BCLC staging system. The most recent one was released in 2018, and even in that more recent addition to it, we have seen a clear separation between intermediate stage and advanced stage disease. So they exist apparently in two separate planets. However, really in clinical practice and in science, this is a very transitional area where both seem to be interacting quite extensively. We saw a lot of clinical trials focusing on overlap of those therapies, and this is exactly the realm where most patients are being diagnosed, and also the realm where we think there is most room of improvement for patient outcomes. So systemic therapies for HCC then and now, I borrowed the slides from Ghassan Abu Alfa, who is a medical oncologist at Memorial Sloan, and this is how the market looked like 5 years ago. We just had one drug, and this it's not even a complete view. This is where we are right now. So within just 5 years, we have so many drugs being approved, and most of them actually are very dedicated, specific targeted molecules and checkpoint inhibitors. So this flood of novel agents actually probably means a left shift of systemic therapy in the BCLC staging system. And what we will witness is a greater overlap between local regional and systemic therapies of immunotherapy. And this is where we come from. We focus now on the biomolecular mechanisms and the tumor microenvironment behind those therapies and their combinations. So we focus on two of the well-known hallmarks of cancer that are particularly relevant for HCC, specifically on its ability to avoid immune destruction and the deregulation of cellular, energetic, and metabolic phenotype. So let's have a look at an HCC cell. So we know it has a very pronounced Warburg effect, and this is specifically a cell that is extremely dependent on the glucose metabolism and so-called the anaerobic glycolysis. And the glucose is being taken up by that cell. It produces lactate. It is essentially decoupled from the Krebs cycle, and this lactate is then being flooded directly into the extracellular microenvironment. And because of that, there is dramatic acidification of the surrounding tumor microenvironment. And what does that really mean for us? The extracellular pH in liver cancer, especially in aggressive HCC, is known to be very, very low. And novel findings say that this is a very important exclusion mechanism for immune cells and a mechanism of immune cell exhaustion. So this has been previously reported, and we now know more than ever that actually tumor-infiltrating T lymphocytes depend extremely on extracellular acidity and competitive glucose deprivation, and that the reversal of this hostile tumor microenvironment can actually improve their infiltration into the tumor and an immune response. So to sum it up, low extracellular pH is a marker of tumor aggressiveness, and the presence of protons and lactate really protects cancer against an immune response. It promotes neoangiogenesis. The lactic acidosis plays a multifaceted role that is not fully understood for all variable immune cell subgroups, and the high lactate levels are actually strong predictors of metastatic disease and poor outcome. So where does all this fit in with TACE? So theoretically, this is an embolotherapy that changes the tumor microenvironment. And what happens is that, in theory, TACE may potentially exacerbate a hostile tumor microenvironment that attenuates treatment efficacy. Let's look at it. I mean, it induces a hypoxic injury that potentially may exacerbate the low pH even further. It potentially stimulates proangiogenic signaling, and the embolization even might prevent the lactate transport away from the tumor. So post-TACE tumor microenvironment was thought to be immunoinhibitory, but is that really true? I mean, let's look at HCC in general, where it stands in terms of genomic somatic mutations, as opposed to melanoma and lung cancer. Really, HCC is somewhere in the middle. So the idea of the immunoinoculation with local regional therapies was initially discarded because of that. So, however, let's have a look at the pathology of a tumor treated with TACE. This is a patient with HCC. Histology was taken 11 days post-local regional therapy. This was a transplant patient. What we see a necrotic tumor packed with, in this particular case, drug-eluting beads. And surrounding that, we see a very dense immunoinfiltrate. And if we zoom in, we really almost see a secondary immune follicles and macrophages and T cells really accumulating the transitional zone, but they can't really penetrate into the necrotic areas of the tumor where all the good antigen is. And why is that? So our mission was at this point to really look at the underlying mechanisms and how do systemic therapies, how does the immune system and local regional therapies interact. So we wanted to develop imaging instruments for non-invasive functional characterization and monitoring of the tumor microenvironment in the setting of the immune response and TACE. And that was the mission of the lab that we essentially started several years ago. So one of the first projects that I'm going to talk about is a recently published paper, Clinical Cancer Research, that focused on the development of an extracellular pH probe that demonstrates extracellular pH non-invasively using spectroscopic methodology. And I'm actually really appreciated because I partnered in design and work on this novel mechanism with Daniel Komen and Hamid Haider from the MR Research Center, who have been really instrumental and great partners in developing this. And we used a model of a rabbit liver tumor, which is so far the only moderate size animal model that has a faithful reproduction of an HCC tumor environment. And has a high clinical relevance because we can do the embolization, also image those animals in real-size clinical scanners. We do have a 3T MRI system for that, and also a cutting-edge IR suite, which we use in the Whitrick with the help and support of Alcinous's group. So this is an immunocompetent host and a hyperglycolytic metabolic phenotype. And essentially, those tumors have been characterized previously as very reminiscent of the actual tumor microenvironment of HCC. So what is a good way to image pH? So there are sensor genes that you can use. There are luminescent probes that you can transfect your cells with, reporters. But what we in radiology aim for is really the non-invasive measurement of extracellular pH. And this is where our MRS-based spectroscopic BIRDS methodology comes into place. This has been established previously in brain tumors by Daniel, and we have translated this essentially to the liver. This is an MR spectroscopic method that measures the redundant deviation of shifts in temperature in the region of the tumor, and we can generate a 3D extracellular pH map that provides us with essentially a very accurate characterization of the tumor microenvironment. So if we look at the tumor in and by itself and measure it as compared to the surrounding liver tissue, we see that the tumor in by itself has a much lower pH at baseline in an untreated fashion than the surrounding liver. And that's important. And we know that this is probably due to the overt Warburg effect and an overexpression of GLUT1 and LAMP2 as indicators for the microenvironment. Now, what does TACE actually do with it? And this is where the surprising result from our study came in. We looked at the effects of embolization with Lipido 1 day, 1 week, and 2 weeks after we actually treat those tumors and measure the pH. And as opposed to most of the assumptions that TACE is going to actually exacerbate the immunologic, the immunoevasive tumor microenvironment, it actually did the opposite. So what we see is a normalization of the tumor pH towards almost liver background levels over time after TACE. And that is an important finding because that gives us an opportunity to use local regional therapy in preparation for a successful anti-checkpoint checkpoint inhibition therapy. And we actually demonstrated this also with a more direct and exacerbated model where we used TACE and actually injected bicarbonate directly with TACE. And what we demonstrated here is that on baseline, you have an acidic tumor. With TACE, you have a minor improvement of pH towards normal overnight, essentially. But if you add bicarb, you can immediately improve the pH almost essentially to normal. And yellow and green means higher levels than blue. If we now look at, for example, HLA-DR expression, at baseline, we see immune cell exclusion. We really see all the immune cells in the tumor periphery. And with TACE alone, immediately, at least 1 day after therapy, you don't really see a lot of immune invasion. But with TACE and bicarb essentially improving and elevating the pH, you see massive intratumoral infiltration of immune cells. And that's an important finding that we made here. And actually, an important other thought that we should be thinking about as a group generally in oncology is what kind of agents we use. So when we use chemoembolization with oil, which is Lipido, we seem to be achieving very different effects as compared to, for example, using oncosyne beads or Lumi beads, which is another flavor of beads. And that is important for us to understand because to the oncologic community, TACE was TACE for a long period of time. But in reality, it is not, because we know that different embolic particles will induce very different immunological effects. and very different changes to the tumor microenvironment. And that is something that we really need to study, especially if we want to combine the local regional therapies with systemic therapies and checkpoint inhibition. Now, another level of investigation that we took and published recently in radiology, again, in close collaboration with Daniel Coleman, Famid Haider, but also other groups like Rick Bocala's group, and also want to mention Ruth Montgomery and Nick Joshi, who helped us generate this research. Here, we wanted to demonstrate that we can actually use molecular dedicated MR probes, nanoprobes, labeled antibodies to visualize the immune system surrounding those tumors in vivo and non-invasively. So what we did is we used both iron oxide particles and the direct injection of gadolinium labeled antibodies to visualize those tumors and put those animals with those implanted tumors into the MR. What we demonstrated was that we were able to clearly delineate macrophage and immune cell infiltration and macrophage and immune cell accumulation in the periphery of those tumors on T2 MR sequences. And that was proven histologically with the Prussian blue staining, which stains for iron. And we saw that the spines, the iron oxide particles, really deposited in CD11b positive macrophages, and we confirmed that later with CD68 staining. And the same thing is true for our induction and injection of gadolinium labeled antibodies. You probably heard about this from the molecular imaging using PET, but here we have a much higher focal resolution where we label antibodies with gadolinium and then inject them directly into those tumors and through the artery, and we can see that there is very specific accumulation and staining of immune cells in the periphery of the tumor that we can now really locally characterize. And that's a big step forward, because not only can we now image the tumor microenvironment from a pH perspective, we can also image it from a presence and functionality of immune cells. So for the first part, the conclusions are the appearance of, for example, more than 5 targeted agents to treat HCC will cause a left shift of systemic therapy in the BCLC, and we really must do some heavy lifting. It's up to IR actually to put the collaboration between the interventional oncology and immune oncology on the right track from a science perspective. We must also work more on non-invasive imaging modalities, and we did so with the extracellular pH that revealed that TACE actually is an inducer of profound changes to tumor microenvironment that may help immunotherapy to be more effective. And pH is key for us as a marker, but the changes in pH depend on the embolic materials that we use. We also now know that CTACE with Lepidol may achieve a partial reversal of the immunoevasive tumor microenvironment on itself 2 weeks after TACE, and that we can use MR instruments to actually detect immune cells directly surrounding the tumor. So in summary, the first part of my conclusion is that local regional therapy and interventional oncology must be established in combination with each other. We have to have a synergy between the two IOs, interventional and immuno-oncology, and it's up to us to work on that. And that generates another bigger problem that we really work upon very closely with Jim Duncan and collaboration with that group and biomedical engineering. And this is the overwhelming growth of data. And we'll be talking about this a little bit later. Tal is going to be presenting on that. So we know that the data that we have specifically in imaging and in cancer in general explodes. So we have more than 20 times more data today than we have in 2013. And so that is a huge challenge. And as David already presented, we have different flavors of chemoembolization, embolization with drug-eluting beads, and radioembolization. We have a variety of different methodologies and ways how we can introduce tumor necrosis, cold, heat, and electrocution in a way. We have 5 different and more coming systemic therapy agents, all of which pose different changes to the tumor microenvironment. So we have an overwhelming burden of complex data that actually may impede effective clinical practice. And we need to address that. And so how do we transform the data from burden to value? We know that we have an increase in data. We have very complex medical health records. We have genomic sequencing information. We have the availability of complex computer-based algorithms, and now the availability of computational power at a lower cost. And that is the space where artificial intelligence now comes in. And this is essentially data-driven learning that deep down can be explained as machine learning that recognizes trends and objects in pre-labeled patterns, or deep learning. And Tala is going to be talking more about that, where we use those networks to actually learn from data without pre-labeling the outcome. And that may hopefully increase the workflow efficiency, improve our diagnostic accuracy, really enable predictive recommendations for us, tailor personalized therapeutic recommendations, and help us introduce precision medicine. But caution is still very important, and AI is being hyped, and I think we need to approach it in a gradual fashion to really see what is doable and what's not. So how can this advanced data analysis help us? It can improve the diagnosis from automation and introduction of novel biomarkers. It can also help us make therapeutic decisions and probably introduce a level of better personalized care. Hopefully, we will be able to ultimately improve intraprocedural guidance, especially now with the introduction of robotics into IR, and specifically follow-up imaging. We hope that in the realm of tumor response and patient outcome prediction directly after the therapies, those technologies will help us put all this data together. Now, prior to introducing the other speakers and giving specific abstract presentations on the two larger topics that I presented, I wanted really to thank the sources of funding, inspiration, and mentoring in our community. I already mentioned Rick. I wanted to thank Jim sincerely, and Todd and David, who joined the lab. Also, great partners of mine are Ruth and Nick, and I really, really appreciate those collaborations that are increasingly interdisciplinary. But at the same time, I wanted to also point out that we in radiology have a very large biomedical imaging collaborative network, and I want to thank Famid and Daniel and Larry and everyone mentioned here, also Al from Whiterick, who have been instrumental over the last 5 years in my personal development and also in the development of the lab. And I think that is the environment that we need, and we need to highlight that to the Cancer Center and introduce it to all of you. And I'm very happy to do so here. And you know, at this point, I would like to thank, on behalf of the Interventional Oncology Lab, which I'm privileged to co-direct with David, and all of our sponsors, and really say that you know, there is one thing across all of this: there is a single light of science, and to brighten it anywhere is to brighten it everywhere. This is our group motto by Isaac Asimov. And with that, I'd like to introduce two of our students that work with us. First, Jessica Santana. She's going to be talking about taking the molecular imaging really to a next level in our new animal models. And Tal is going to be talking about his role as a biomedical engineer and a graduate student within the biomedical imaging sciences, and focusing on predicting outcome and recurrence of HCC after intervention. And I'd like to now stop sharing the screen and give it to Jessica.
Hi all, I'm Jessica. I am a master level immunologist and a graduate student at the Yale Interventional Oncology Lab, and I'm very excited today to be presenting my work titled Non-Invasive Molecular Imaging Allows Characterization of the Immune Response Following Hepatic Radiofrequency Ablation in a Mouse Model. Nothing to disclose. So giving you a brief overview on hepatocellular carcinoma. So as we know, this is a classical inflammation-associated carcinoma, and now is the third most common cause of cancer-related death worldwide, with the majority of patients being treated with local regional therapy as the main alternative option over surgery. However, the problem with local regional therapy is that a significant fraction of patients, they tend to recur, and the causes for recurrence can vary a lot. And it has been suggested, for example, that the immune response to radiofrequency ablation can play both roles in pro-tumorigenic side effects, as well as abscopal effects that in turn can positively impact the immune response to cancer. However, we have currently no instruments that would allow us to non-invasively monitor such immune response. So the purpose of this work is to develop a non-invasive molecular imaging instruments to visualize such immune response to thermal injury following RFA. So our group has built a translational mouse model of radiofrequency ablation as a platform to develop and validate MR-based immunoprobes for in vivo imaging of the immune system. And based on our findings, we have observed that there is after radiofrequency ablation in the normal liver, there is a strong time-dependent local infiltration of immune cells that orchestrates the tissue healing process. And there is an overtime transitional zone of those immune cell infiltrate. So having a specific cell population locally present at the transitional zone between the necrotic area and the normal living parenchyma at a specific time point serves us as an in vivo platform to build and validate our dedicated immune probes. So guiding you through our experimental design, we have ablated a normal liver of a mouse. And after characterizing a large infiltration of a specific cell population at a specific time point, we have established a dedicated gadolinium labeled antibody that was delivered systemically to target a specific cell population at the chosen time point post-ablation. And a second immunoprobe also used in this study is the small iron oxide particles. And we know that iron particles, they have been largely used in the clinical setting as a dark contrast agent. And once they are delivered systemically, they're able to be phagocytosed by circulating phagocytes that once they migrate to the site of inflammation, they can cause a local deposition of iron. And in this study, we have demonstrated that both gadolinium labeled antibodies and SPION probes, they were able to be imaged using a higher resolution MR animal scanner. So in our first setting of experiments, we have demonstrated that the ablation zone itself can be easily imaged on a 9.4 Tesla Berker. So here on your left, you have the picture taken seconds after ablation to show you or give you an idea of how the ablation site looks like. And 1 week post-ablation, we have delivered pure gadolinium systemically, and we ran a T1 weighted MRI sequence, and we could see precisely the ablation site. And on your right, we have an ex vivo confirmation of what we see on the MRI. But you might have been wondering why exactly 7 days post-ablation. So to the best of our knowledge, we know that RFA-induced thermal tissue injury largely contributes to a strong time-dependent innate immune response at the margins of the necrotic zone. And according to our findings, we have observed the largest accumulation of CD68 positive macrophages in the transitional zone precisely 7 days post-ablation. So this is the time point we decided to base our experiments on. So we have decided to deliver systemically those iron oxide particles 7 days post-ablation. And we have confirmed that there is a local deposition of those iron oxide particles exactly 24 hours after systemic delivery at the transitional zone. So here we have an ex vivo Prussian blue staining of a 1 week post-ablation mouse liver 24 hours after systemic delivery of SPIONs. And when we imaged those animals, we could demonstrate an in vivo local deposition of those phagocytes at the transitional zone. So here on your left, you have a T2 weighted MRI of a 1 week post-ablation 24 hours after systemic delivery of SPIONs. And as a red path correlation, we confirmed ex vivo specific deposition of SPIONs at the transitional zone through immunofluorescence and Prussian blue staining. And as for our gadolinium-based immunoprobes, we have used a anti-CD68 antibody tagged with gadolinium. So after ex vivo observing a massive infiltration of CD68 positive macrophages in the periablational zone, we delivered gadolinium tagged with CD68 systemically and was able to see a specific deposition of those cells in the periablational rim. So here on your left, you have the ablation site, the picture taking seconds after ablation showing the ablation site. And we also have a T1 weighted MRI 1 week post-ablation after 24 hours with gadolinium CD68 delivered systemically. And on your left, you have the picture taken ex vivo confirming of what we've seen on the MRI. And to confirm that this periablational dark rim is seen precisely in animals receiving those CD68 tagged, CD68 antibodies tagged with gadolinium, we also ran T1 weighted MRI with pure gadolinium. So on your left, you have the baseline, and in comparison, we have a T1 weighted MRI with pure gadolinium injected. And we have confirmed that only with animals receiving CD68 tagged with gadolinium, we have this precise perioblational rim showing a local infiltration of CD68 positive macrophages, and therefore an in vivo visualization of those cells. We have also confirmed ex vivo specific labeling of immune cells using imaging mass cytometry. So here on your left, we have the T1 weighted MRI of 1 week post-ablation after gadolinium labeled antibody administration, where you can see the rim of the local deposition of the infiltrating cells. And on your right, we have the ex vivo confirmation with the imaging mass cytometry of local deposition of the CD68 macrophages in the transitional zone. So as the main conclusions and findings of this study, it tells us that both spines and gadolinium-based molecular imaging allows for specific labeling of locally immune infiltrate. And this is also a translational study with the proof of principle for the feasibility of the MR imaging of macrophages on a 9.4 Tesla MR scanners. And also tells us that non-invasive in vivo detection of the immune system can be achieved using dedicated immune probes. And as for our future perspective and clinical application, we can have this as a useful tool to study and characterize the interplay between the tumor microenvironment and the immune cell activity in vivo. And also gives us the possibility to integrate complementary molecular MR imaging of the immune system and, let's say, the extracellular pH in a liver cancer model for simultaneous characterization of this immunometabolic crosstalk. This also serves us as a platform to study strategies for local modulation of the immune microenvironment towards a immunopermissive phenotype, and can also serve us as a theranostic immunotherapy. So I would like to thank you for the opportunity to present this work, as well as the Yale Biomedical Imaging Department. And now I'll give you the word to my friend Tal.
Hello, everyone. My name is Tal Zeevi, and I'm a graduate student in the Biomedical Engineering program here at Yale. And I'm a member of the Interventional Oncology Lab since 2018. And today I'm going to be presenting our project on deep learning use to predict disease recurrence of HCC based on MR imaging. So a little bit about HCC. So HCC is a primary tumor of the liver that usually develops in the setting of chronic liver disease. And while the diagnosis of HCC could be made by imaging alone, sometimes a biopsy may be required to support this diagnosis. A little bit statistics, every 40 seconds, a patient diagnosed with HCC. In 2020 alone, the death rate is approximated to be 800,000 deaths worldwide. HCC may recur, and there is no significant imaging biomarker or clinical biomarkers to reliably predict recurrence before allocation to treatment. One of the treatment is liver transplantation. It helps to decrease the chance of disease recurrence. However, we are all aware to the shortness of organs. Therefore, two criteria of allocations of livers are being used. One of them is the Milan criteria, which was presented in 1996, and the other one was presented by the University of California, San Francisco in 2001, basically extended this Milan criteria. Both of them are based on low-level handcrafted features such as tumor size and number of tumors. And even though using these criteria, we are seeing 15 to 20% of transplanted patients reoccur within the first 5 years. So as I said, these two criteria, allocation criteria, has suffered from false positives. And our hypothesis is that there is more information in radiological images, specifically MRI, that correlate with HCC recurrence than the naked eye could detect. And the way we're going to try to test this hypothesis is by using deep learning algorithm to extract features from MRI imagings and try to use them to correlate to HCC recurrence. And a little bit before I start talking about our methodology, I will talk about data-driven predictive modeling and a little bit about deep learning. So when we talk about data-driven predictive model, we usually refer to two different variables, the explanatory variable and the explained variable, our target. And we want to take these explanatory variables to feed them into a predictive model, which will give us the outcome of our target model, which could be recurrent or not. And these predictive models has different shapes and algorithms, which you may heard, for example, neural networks, decision trees, SVMs. All in all, these all algorithms that try to do the same thing. They try to create or to estimate a mathematical function that correlates this input into the output. And there are two main elements of this estimation process. One of them, we are trying to see what is the mathematical element, the interaction between our features and the mathematical operations that's going to be incorporated within this mathematical function, for example, the multiplication of x1 and x2. And the second thing, we're trying to estimate the weight of these mathematical elements within this function, which could be seen here as beta 0, beta 1, etc. And I'll give a short and very simplistic example of this data-driven predictive model. So here we are having only one variable, explanatory variable, which is the age, and we're trying to predict a disease, if the patient is positive or negative to a disease. So for example, in the right side of the screen, we can see this mathematical function. Y would be considered positive if the age is greater than beta, otherwise negative. And as we get more and more examples, we could estimate this beta. For example, here we're estimating beta to be 60. But as more data comes, we can update, modify our weight and basically change our function. And everything is okay till we have a data example that prevent us from creating to use this mathematical function to separate between these two groups. So here we need to incorporate a new feature, for example, weight. And when we are doing that, we can create a more complex function to separate these two groups. And basically, this is what we're going to try to do today. We're going to try to find the features that will allow us to separate between the recurrence and non-recurrence groups. When we're talking about deep learning, we're basically usually refer to neural networks. And neural networks is, again, an algorithm that allows us to approximate almost any mathematical function that correlate input into output. And it does that by finding interaction between features. Convolutional neural network allow us to search for repetitive patterns within an image and then correlate them to the output variable. So it allows us to find high-level features such as edges, and the more deeper we go, the more complex the feature become and allow us to separate between the groups that we're trying to separate. A little bit of our data. So we had 120 patients, 18 years old or older, 88 male and 32 females. All of them were diagnosed with HCC between the years 2005 to 2018. So the patient went into MRI imaging, then were diagnosed with HCC, and then got treatment. 29 ablations, 32 resections, and 59 transplantations. And time went by, some of them recur, and some of them stop their follow-up, which we consider to be non-recurrences. To this time, we call time to recurrence, and this would be our explained variable, the variable that we are going to try to predict. With respect to our input data, we're going to use contrast-enhanced multi-phase liver magnetic resonance imaging, MRI, and we're going to use 3 different phases, the arterial, the portal venous, and the delay. So the question that we're trying to answer here is, can we predict HCC recurrence using pre-treatment MRI images? In other words, are there visual features in pre-treatment MRI that correlate with HCC disease recurrence? So to visualize that, we're going to use the input MRI, the MRI as an input data to feed them into a predictive model, which will be convolutional neural network, and to predict whether the patient will recur within 1 year, 2 years, up to 6 years after treatment. So here are the results. Here we can see the results for these 6 time frames. So 1 year of recurrence, 2 years of recurrence, up to 6 years of recurrence. And this figure present the relationship between the true positive rate to the false positive rate on our test cohort. And seeing this 45% curve, which represent basically a random chance to predict, we can see that all of our curves is above that, which means that our model has prediction power. Another analysis that we did was to try to use Kaplan-Meier curves and our predictions to separate our cohort into two risk groups. So low risk group to recurrence and high risk group to recurrence. And we got significant results for recurrence-free survival for 4 out of the 6 timeframes. Here you can see the 6 different figures each for each time frame. So to summarize, the current state-of-the-art criteria based on low-level handcrafted radiological features such as tumor size, number of tumors. And this study showed that there are still unknown visual features in pre-treatment MRI that correlate with recurrence of HCC. Secondly, the current state-of-the-art selection criteria suffers from false positives, and we showed that by incorporating machine learning-based algorithms, we could potentially improve the prediction of HCC recurrence. A little bit of limitations in future research. We used a single site cohort from Yale Hospital, which was small, 120 patients, which has the limitation of generalize the results for other sites, and therefore we'll need to increase our sample size or incorporate in patients from different sites. And maybe single data modality may be not enough. So in future research, we recommend to test the interaction between imaging and clinical data, even incorporating more imaging modalities. Thank you very much.
So that was really great. I hope you all were able to see what exciting work we're doing in this lab. Does anybody have any questions?
Yeah, and individuals can certainly submit their questions on chat, but we did receive one, which David, you took the liberty of at least answering online, but for the benefit of all, let me just toss this out. So Joseph Kim asked, essentially, how do you decide on the specific procedure, be RFA, thermal ablation, cryoablation, and also relative to contraindications? How do you make those choices?
Yeah, so I guess I gave a pretty long email for a chat, but or a comment for a chat, but each ablation modality has its pros and cons. And clearly my goal for today was not to go into my own personal research and discuss a lot of this stuff in depth, because I really wanted to highlight our trainees. But basically, for liver, it's pretty much understood that heat ablation is actually what is preferred. And that's because over the years, well, first of all, it's very effective. But over the years, there's been concerns with cryoablation on something called cryoshock. There's questions about fracturing the liver. There's no way of really cauterizing any bleed that you can do with microwave or RFA, and a whole bunch of others. So it's really the complications in this setting that makes it less ideal than for the heat base. Now, the one positive thing, as we've shown in one of the cases, is that you do get the ice ball, which has low density ice, and that actually allows the operator to really sculpt the margins of where you want to treat. In other organ systems, like the lung and the kidney, it's really a dealer's choice. So that there have been papers on both in terms of using cryoablation or heat ablation for those. Now, we were just involved in a study that was recently published in the Journal of Thoracic Oncology, which was a prospective clinical trial called Solstice that did show benefits of cold, for lung nodules. And then IRE, as I kind of explained, it's kind of a niche application, mostly used in pancreas, but it's in an area where it's difficult to treat, areas which have, vital structures nearby. So that's the, I guess, summary of that. So thanks.
So let me ask a follow-up question, because a great deal of the work is really advancing understanding the nature of the immune infiltrate post-procedure, and moreover, how to make the environment more hospitable to immune cells. So let me ask, be it both with regard to the imaging techniques, monitoring techniques, and perhaps the introduction of bicarbonate, how might you leverage all of this to think about combining these approaches with ongoing immunotherapies that are under development in HCC?
Right. I mean, that's a really important question that we are actually trying to answer ourselves. As David mentioned, I mean, we're right now actually submitting one R1 application after the other because we want to investigate exactly those points. We generated this preliminary data. Now we want to take it to the clinical perspective and do also trials in the immediate future. So I think there's a couple of limitations that we first need to address. And for the pH imaging, this is certainly the contrast agent, which has not been yet applied in the human scenario. So we need to make sure that we can do that safely. Secondly, I think the imaging of the immune system is a very hot topic and is being hotly discussed and worked upon both by the nuclear medicine community as well as us. And I think that both approaches have their merits and their drawbacks. And I think that this will definitely bring a breakthrough in terms of imaging biomarkers. As we know, in HCC, only 20% of the patients at roundabout respond to immunotherapy, but we treat a lot of them with it. And so we want to make sure we choose the right patients for the right therapy, and that's the whole goal. As for the real application of bicarb, that is an approach that could be translated into clinical trial very easily. I mean, bicarbonate is not a harmful substance. It could be used in just used in a clinical trial with TACE. And I think we need to really think about using that as an additional arm, possibly in one of the clinical trials that David is bringing on board to use TACE in combination with the immunotherapies. And I think that would be a very simple initial fix to do that. I mean, there is very little harm and probably, some major benefit that we could get from that. So we need clinical trials in this respect, and we need more translational contrast agent and MR research. And I think we do have an amazing infrastructure with our MR research center here and the PET center on the other hand to actually do that kind of research.
And so let me, as a follow-up, let me ask, given what you're describing and the nature of the immune response, the immune environment, after procedures such as these, does that potentially suggest that any efforts right now to combine a checkpoint inhibitor with TACE or other ablation procedure may not be yet optimized to really achieve what we hope they would achieve because of the nature of the environment?
Absolutely, and this is exactly what I showed. If you remember, one of the slides had different embolic agents, and so we're using various embolic agents, various agents that we inject into the tumor that may be pro or anti-inflammatory. We then also combine TACE and checkpoint inhibition in tumors that may be hot or immunologically cold. So essentially, a lot of these trials will probably have very non-significant results and probably will never achieve a certain level of clinical translation that we hope for, just because we don't know what we're doing, essentially. So when we combine interventional oncology and immune oncology, we just go about it and say one size fits all. And that is something that I feel like is the major key point that we need to address. And one of these issues is that in the interventional oncology community, we just did not have the academic culture and research environment so far, and this is across multiple institutions across our entire community, to actually tackle those topics. And I think now as we more understand that our therapies are necessary and are increasingly combined with systemic therapy, we need to investigate that. And I think that we're going to have major breakthroughs in the next 3 to 5 years.
Thank you. Well, I know we're at the top of the hour, and I want to thank Jessica and Tal and Julius and David for really a remarkably stimulating body of work and really bringing to our attention what can be accomplished in interventional oncology. So, thank you for this continued education and for the great work you're doing. And to everyone online, thank you